Hello everyone, welcome to Pathology Concepts. We are learning about malaria today. In this topic, we discuss about its life cycle, symptoms, and how malaria is diagnosed on thick smear and thin smear. Malaria has been major disease of humankind, occurs due to the infection of Plasmodium species. Plasmodias are protozoa. It occurs due to the bite of infected female Anopheles mosquito, a uninucleate sporozoite in salivary glands of infected mosquitoes are injected into a human host when mosquito feeds, and this is how malaria occurs. There are more than 100 species of Plasmodium which can infect many animals. 5 species of the Plasmodium have been recognized to infect humans. They are Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, Plasmodium malariae, and Plasmodium knowlesi. Let's see different forms of the parasite. First, we see the Plasmodium falciparum. This is the seasoned form. Next is a ring form. This is the ring form on the thin smear. This is ring form with Murer's cleft. And this is the gametocyte. This is the seasoned of Plasmodium vivax which ruptures into the merozoite. It is a ring form on the thick smear. Ring form on the thin smear. This is again a ring form. This is the trophozoite. Trophozoite with Schuffner's dot. This is also trophozoite. This is the gametocyte of Plasmodium vivax. This is also a gametocyte. This is the ookinete. Now we are learning the form of Plasmodium malariae. This is the seasoned. Ring form. Trophozoite. Trophozoite. Gametocyte of Plasmodium malariae. Now we learn Plasmodium ovale forms. Seasoned of Plasmodium ovale. Ring forms. Trophozoite. Trophozoite. Gametocyte. Plasmodium knowlesi schizoid form. Ring form. Ring form. Trophozoite. And gametocyte. Let's learn about the life cycle of malarial parasite. This involves cyclical infection of humans and the female Anopheles mosquitoes. Let's focus on the right upper corner of this picture. During a blood meal, a malaria-infected female Anopheles mosquito inoculates sporozoites into human host. These sporozoites infect the liver cells. They mature into the seasons. The seasons which rupture and release the merozoites. This whole cycle is called the exoerythrocytic schizogony. After replication in the liver, parasites undergo asexual multiplication in the erythrocyte, which is called the erythrocyte schizogony. Let's focus on the lower right corner of this picture. Merozoite released from the schizont infect RBCs. These infected RBCs harbor ring stages and trophozoites. Some of them mature into the schizonts and some of them differentiate into the sexual erythrocytic stages, also called the gametocytes. These blood stage parasites are responsible for the clinical manifestation of disease. Let's focus on the left side of this picture. Gametocytes. The male gametocyte and the female gametocyte are ingested by an Anopheles mosquito during a blood meal. A parasite multiplication in the mosquito is known as the sporogonic cycle. While in the stomach of mosquito, microgametes penetrate the macrogamete, generating the zygotes. The zygote in turn become motile and elongated. It is called the ookinetes. These ookinetes invade the midgut wall of the mosquito where they develop into the oocytes. These oocytes grow, rupture and release the sporozoites. This sporozoid reaches the mosquito's salivary gland, and these sporozoids enter into the human host while mosquito is feeding on a human blood. So the cycle is completed here. Plasmodium passes through number of different stages of life in their two-host life cycle. The stage infective to human is uninucleate lancet-shaped sporozoids. The exoerythrocytic phase usually takes 5 to 21 days depending on the species. In Plasmodium vivax and Plasmodium ovale, a dormant stage also called the hypnozoids can persist in the liver and can cause the relapse by invading the bloodstream weeks or even years later. Let's learn the clinical manifestations. Patients have fever, chills, sweatings, headache, weakness, and other symptoms mimicking a viral syndrome. Diarrhea, abdominal pain, and cough are occasionally seen. There is a classical malarial paroxysm occurs with a bout of illness alternating with the symptom-free periods. Three successive stages of paroxysm is: first is 15 to 60 minute cold stage characterized by the shivering and the feeling cold. Second is 2 to 6 hour hot stage. There is a fever reaching 41 degrees centigrade. Flushing, dry skin with nausea and vomiting is seen. Third stage is 2 to 4 hour sweating stage, during which the fever drops rapidly and patient sweats. The febrile response is due to the rupture of mature schizont in the RBC. In Plasmodium vivax and Plasmodium ovale, the schizont ruptures every 48 hourly, also called the tertian malaria. In Plasmodium malariae, fever occurs every 72 hours, also called the quartan malaria. Plasmodium falciparum shows no distinct periodicity. In Plasmodium knowlesi, fever occur every 24 hours, also called the quotidian pattern. This classic fever pattern are usually not seen early in the disease course. So the absence of periodic synchronized fever does not rule out the diagnosis of malaria. Other findings may be present are splenomegaly, hepatomegaly, jaundice, hypotension, abdominal distension, tenderness. Lymphadenopathy and the rash are not seen in the malaria. Let's see the pathogenesis. When the schizont mature into the RBC and rupture and release the merozoites in the bloodstream, this triggers the immune response. The cytokine, reactive oxygen species, and other cellular products released during this immune response, they are the cause of the fever, chills, sweat, weakness, and other symptoms. In falciparum malaria, infected RBC adhere to the endothelium of capillaries and the postcapillary venules, leads to obstruction of microcirculation and tissue anoxia. In the brain, it causes cerebral malaria. In kidney, it causes acute tubular necrosis and renal failure. In intestine, it causes ischemia and ulceration leading to GI bleeding and bacteremia. Anemia is dependent on the degree of parasitemia. The cause of anemia here are hemolysis, phagocytosis of parasitized RBC, and ineffective erythropoiesis. Some protective factors are also seen with malaria. Examples are sickle cell anemia and trait. The patients with sickle cell anemia or trait rarely exhibit the falciparum malaria disease because the falciparum develops poorly in their RBCs. The second is Duffy blood group antigen. Duffy blood group antigen absence on the RBC protects against the P. vivax malaria because Duffy blood group antigen functions as a RBC surface receptor for the P. vivax merozoites, and without this antigen, parasite cannot invade the RBC and thus protect the host. Third is malarial parasite does not develop well in the ovulocyte. Let's see how the malaria is diagnosed. It is done by identification of plasmodial parasite in the thick and the thin blood smear. It is a gold standard for diagnosis. Other tests available for the detection of malaria are rapid malarial antigen kits, molecular methods including the nested and real-time PCR, and the LAMP. LAMP is loop mediated isothermal amplification. Other laboratory abnormalities seen are normocytic normochromic anemia, thrombocytopenia, leukocytosis or leukopenia, hypoglycemia, hyponatremia, elevated liver and renal function tests, proteinuria, DIC, intravascular hemolysis with hemoglobinemia and hemoglobinuria. Identification of the species and the stages of malarial parasite and the determination of their density is crucial in the clinical management of the malarial patients. Parasite density provides the information on severity of infection and on the response to treatment. All identified parasite species should be reported. Gametocytes are not counted, but their presence is always reported. And also, presence of schizonts are reported as they might be an indicator of disease severity. In thick smear, there is an increased sensitivity for the parasitic detection as compared to thin smear. and it is a gold standard method. Thick smear contains the greater density compared to thin smear. Most parasite count performed on the thick blood films. Thin blood film count is also performed when there are more than 100 parasites in the each field of thick film, which corresponds to more than 80,000 parasites per microliter. Let's see how to screen for malarial parasite in the thick smear. Place the Giemsa stained blood smear to be examined on the microscope stage with label to the left. Position the thick smear in the line with 10x objective lens. Scan the blood film for the parasite and the blood elements. Select the part of the film that is well stained and has evenly distributed white blood cells. Place a small drop of immersion oil on the thick smear. Switch the 100x immersion objective over the selected portion of thick smear. 15 to 20 WBCs per thick smear field will give a satisfactory smear thickness. A smear with fewer WBC per field will require more extensive examination. Examine the slide in the systematic manner. Start at the top left of the smear, marked with a vertical green arrow, and begin at the periphery of the field. Then move horizontally to the right, field by field. Examine the 100 fields of thick smear to detect the presence of malarial parasite at 100x oil immersion. When the other end of film is reached, move slide slightly downward and then to the left, field by field, and so forth. Minimum 100 high power fields must be examined before declaring the no malarial parasite seen. If possible, whole thick smear should be scanned. If malarial parasites are present, count the asexual forms in either single or mixed species infection without sexual or called gametophyte forms, which are not counted but reported. In mixed infection, all forms are counted together and the presence of multiple species is reported. Count parasite and WBC simultaneously. After counting all parasites and WBC in one field, move to the next, following the pattern. If you have counted more than 100 parasites in 200 WBCs, stop counting and record the result as a number of parasites per 200 WBCs. If you have counted less than 99 parasites in 500 WBCs, stop counting and record the result as a number of parasites per 500 WBCs. Record all malaria species and the stages observed. Formula to count the parasite density. It requires patient's actual WBC count. If it is not available, use an estimated average WBC count of 8,000 per microliter. Use the following formula for calculation. That is, parasite per microliter of blood is equal to number of parasite counted into 8,000 WBC per microliter upon number of WBC counted. These are some of the examples of the formula how to count parasite density. Another system is a grading system for counting. To indicate the level of parasitemia or parasite density in the positive cases, the number of parasites in the thick smear was graded using a plus system scale. Plus 1 here is 1 to 10 parasite per 100 thick smear fields. Parasite density is equal to 4 to 40 parasite per microliter. Plus 2 is 11 to 100 parasite per 100 thick smear fields. Parasite density is equal to 40 to 400 parasite per microliter. Plus 3 is 1 to 10 parasite per 1 thick smear field. Parasite density is more than 400 to 4000 parasite per microliter. Plus 4, more than 10 parasite per 1 thick smear field. The parasite density is more than 4000 parasite per microliter. As a standard quality control procedure, all the positive blood smear and 10% of randomly selected negative blood smear should be cross-examined. Let's see how to count parasites on the thin smear. If more than 100 parasites are present in the each field of thick smear under the 100x objective, calculate the parasite count in the thin smear. Examine the feathery edge of the thin smear where the RBC lays side by side and there is a minimal overlap. Locate a field with about 250 RBCs. A typical field should contain 250 RBCs. Move along the edge of the film, then move the slide outward by one field and inward by one field, returning in a lateral movement and so on. Stop counting when 20 field, about 5000 RBCs have been counted. When the counting is complete, calculate parasite density from the patient's actual RBC count. The formula here is parasites per microliter is equal to number of parasitized RBC into 50 lakhs upon number of total RBC counted. Another formula is percentage parasitemia. The formula is parasitized RBC into 100 upon total RBC. Percentage parasitemia is very important for the P. falciparum infection. This is all about malaria in short, and these are the references. Hope you like it. Thank you.